What are the most common pitfalls physicians make when evaluating a patient for PAH?
This is a really important question because we have learned from some of our clinical trials that the guidelines aren't followed as much as they should be when we try to work up and diagnose a patient with pulmonary arterial hypertension. So the echo, as I mentioned, is often a first stop. And if a patient has an elevated right ventricular systolic pressure on echo or an enlarged or dysfunctional right ventricle, further evaluation ensues. I think one important pitfall is to think that echo can make the diagnosis. Certainly no patient should be treated with PAH therapy on echo alone. A right heart catheterization is really critical to make the diagnosis of PAH. We need to measure not only the pulmonary artery pressures, but also the left heart filling pressures, because diastolic dysfunction is a very common cause of Group 2 or pulmonary venous hypertension, and that's treated very differently. So paying good attention to the echo as a starting point, but making sure you proceed with the rest of the evaluation, which culminates in a right heart catheterization. One cannot make the diagnosis of PAH without a right heart catheterization. And then the other test that is commonly overlooked is a ventilation perfusion scan. And this is absolutely critical to evaluate for chronic thromboembolic pulmonary hypertension. It's not particularly common, but it is potentially curable with a surgery called a pulmonary thromboendarterectomy. Or if a patient has disease that's too distal, there may be other therapeutic options available. So it's very important to rule out that as an etiology because the treatment is so different.